Hello, and thank you for tuning into this podcast created by Doctors Matthew Lin and Ed Kim. Today's topic is on acute abdomen, Part 1, a common mechanism. The goal of this podcast is not for rote memorization of random facts. You guys have already done that for your first 2 years of medical school. The goal of this podcast is to develop a common conceptual framework for acute intra-abdominal disease processes. This can be done by correlating pathophysiology and anatomy with a patient's physical exam, and thus creating a story that is easy to remember and help navigate through different clinical scenarios. In this podcast, we will use cholecystitis and appendicitis to illustrate our point. In this slide, what is the body's first line of defense against pathogens? Typically, one is taught in medical school that the different types of cells that participate in the immune systems, such as neutrophils, are the ones that are the first lines of defense against pathogens. Let us shift gears and start with the concept of barrier mechanism as opposed to the immune system. It is much easier to picture. Natural barriers such as a squamous epithelial lining found on the skin or the columnar lining on the GI tract are the first line of the defense system. This slide is a very simplistic, but yet effective way of communicating what we're trying to describe. We're just trying to keep the barbarians out. You see an ancient fortress surrounded by walls. In this case, both our skin and our GI tract lining are designed to keep out common pathogens. A robust wall keeps out the pathogens. For the GI tract, the columnar epithelium provides a wall to keep out invaders, unless if it is overwhelmed by a powerful pathogen, such as either Salmonella or Clostridium difficile. Another possibility of a breach is when the integrity of the epithelium has been structurally compromised. Once again, to emphasize a key concept, we have to understand that the body has a natural defense barrier. Usually there's an inciting event that causes a breach. There's usually an event such as a form of obstruction in blind lumen, which you see in this case. What other organs can you think about that looks like a blind lumen? Both the gallbladder and appendix are both blind lumens. Colonic diverticula are also blind lumens. Gallstones, fecal material can obstruct the opening to these structures. This slide shows a sequence on how acute abdomen develops. Obstruction of the blind lumen will result in distension of the organ or segment of organ involved. Think about Laplace's law from your undergraduate days. Distension increases pressure that will block venous outflow, meaning blood perfusing the organ cannot exit the organ and thus cause a backup, much like the Bay Bridge. The congestion of blood prevents blood from flowing through the capillaries and thus prevents oxygen delivery. Now the organ is ischemic, being deprived of oxygen. This results in infection and or inflammation. If the infection or inflammation are left untreated or continues to persist despite treatment, they will lead to necrosis and subsequent perforation, resulting in an acute abdomen, also known as peritonitis. So what are the symptoms? We need to think about visceral versus parietal pain. Vague visceral, general abdominal pain, focal tenderness, and subsequent diffuse rigid abdomen. Let's use the example of appendicitis. Visceral pain is general pain. It is not well localized. When the fecal lip obstructs the appendix, this will result in distension, thus activating the visceral pain fibers. This will result in general discomfort, but not well localized. And usually, it is not uncommon to hear patients that their pain first began around the periumbilical region. When the appendix becomes much more distended, this will trigger the parietal pain receptors in that region, resulting in localized severe pain. Subsequently, from increased distension, the appendix itself will become necrotic and unfortunately will perforate. If more stuff is leaking out from the perforation, more organs will come into contact with the irritating infectious fluid, thus triggering further parietal pain, resulting in diffuse parietal pain and most likely a rigid abdomen. Let's apply the same concepts we just learned to the gallbladder. Here is a slide showing the symptoms for the progression of biliary colic to acute cholecystitis. There's luminal obstruction. Biliary colic occurs when the stone obstructs the cystic duct. There's visceral pain as the gallbladder becomes more distended. However, this pain usually disappears once the stone dislodges. Think of it like a ball valve. When the ball, or stone in this case, covers the opening, the pressure increases. Once the stone is no longer obstructing, then pain is relieved. However, ask yourself, what happens if that stone doesn't move? This will lead to eventual acute cholecystitis. The stone obstructs, leading to prolonged distension, leading to ischemia. Ischemia then leads to compromised mucosal integrity. Now that wall has been breached. This will allow for bacterial infiltrations, leading to inflammation and infection. This is a slide that you have already seen before, but let's do it in the context of gallstones. Biliary colic leading to acute cholecystitis due to, once again, obstruction, distension, increased pressure, thus leading to ischemia at the capillary level, resulting in infection, inflammation, with subsequent necrosis leading to perforation. Now let's think about the clinical presentation of both biliary colic and acute cholecystitis. Patient will start with visceral pain in either the epigastric or right upper quadrant. There will be a longer duration of pain in acute cholecystitis since the gallstone isn't dislodged. This usually lasts for approximately 4 hours. Systemic symptoms will then present itself, such as fever, tachycardia, and leukocytosis. Imaging is often needed to help confirm the diagnosis. This slide demonstrates radiographic findings for acute cholecystitis. On the left, it shows a gallstone in a non-inflamed gallbladder. On the right, it shows the gallstone as noted with echogenic shadowing on ultrasound, but also ultrasound signs of inflammation. Inflammatory signs such as edema are indicated by the blue arrows, the thickened gallbladder wall with the red arrows, along with possible surrounding fat stranding. This is acute cholecystitis. In summary, any type of obstruction of a blind lumen will lead to distension, resulting in increased pressure. The increase in pressure causes ischemia, leading to the breakdown of the body's natural wall defense. This allows bacteria to break through, resulting in inflammatory changes. If not treated, the wall may completely perforate, resulting in peritonitis. This common concept will help you develop the framework and hopefully mental images on the development of acute peritonitis without too much rote memorization. Thank you so much for tuning in.